Okay, the logins seem to be slowing down a bit, and it's a minute or so after 1. So I want to welcome everyone to our training session today. My name is Susan Jenkins, and I'm the director of the Division of Evidence Evaluation and Data Policy and ASPE's Office of Science and Data Policy here at HHS. I apologize for not showing my camera, but 15 minutes ago it decided it wasn't going to work anymore. But I am happy to be here with you. And I want to give a little background as to why we are doing this training and what this training is. So this is part of HHS's response to the Foundations for Evidence-Based Policymaking Act. And as part of that, we assess departmental capacity in a range of evidence-building areas. One of the areas that rose to the top was a need for better understanding of program evaluation amongst people most likely to benefit from program evaluation. So this is not evaluators themselves, although you're welcome to join the session, of course, but this is for other folks who may wonder, how does evaluation work? Why should I care about evaluation? So this first session is part of a 3-part series. There's a session today, a week from today, and 2 weeks from today. And during this session, we will cover how and when evaluation is most useful, the varying types of evaluation and when each is most appropriate, and why evaluation is a vital tool for program planning, management, priority setting at both the program level and at the agency, office, component, or division level. In the next session, we'll focus on ways to engage with the evaluation process so that you can get the most out of it. And in the third session, we will address appropriate use of evaluation data to inform programmatic and policy decisions. So a few housekeeping items. We are recording this session, and so it will be made available likely through the ASPE website in a few weeks or so. Captions are available for this session, but you need to turn them on if you want to use them, but they are available to you. And if you have questions for the speakers, please submit them in the Q&A tool throughout the presentation. And we have planned about 10 minutes at the end of the presentation for answering those questions. And we'll collect those questions. And if there are more than we can answer, we'll do a frequently asked questions and post that at the same time that we post the slides, the recording, and any other materials related to this session and the series. And so our speaker today, we're very excited. The speaker today and for the next 2 sessions is Dr. Elizabeth Yano, Becky. And Dr. Yano is an adjunct professor at Health and Policy Management at the UCLA Fielding School of Public Health. Dr. Yano is trained in healthcare epidemiology, biostatistics, and health policy at UCLA and RAND. Dr. Yano has over 30 years of experience in health services, research, and program evaluation at UCLA, and teaches evaluation of health services in the executive M.P.H program. And I have spoken to Dr. Yano, and so while may sound very nerdy, very technical, which she is, she's also very personable, and I think you will very much enjoy this session. So with that, I will turn it over to Dr. Yano.
Thank you so much. Let us go ahead and dive in. So it's a pleasure to speak with you today about, I need to share my slides. So sorry. There we go. It's a pleasure to speak with you today about using evaluation to develop evidence, the how and the why, as Dr. Jenkins mentioned. So this is, as already mentioned, first of a 3-part series focused on the key principles of evaluation in the federal context. And as mentioned, the sessions will be recorded and made available later. In this part, we all are going to focus on how and when evaluation is useful, the varying types, and why evaluation is a vital tool, as already mentioned. And we will have these 10 minutes at the end. And it's my understanding that we will want you to actively engage in the Q&A section along the way, and we'll aim to respond in real time to the extent that we can. So what is evaluation? The Office of Management and Budget has laid out a definition of evaluation as an assessment using systematic data collection and analysis of one or more programs, policies, and organizations intended to assess their effectiveness and efficiency. Another definition is judgments of worth. reached by weighing information against some explicit or implicit yardstick. I prefer explicit ones because they're measurable, but that yardstick may be statistical significance, clinical relevance, comparisons against a regional or even arbitrary standard. Either way, it's important to have those notions up front. Another definition is a management or decision-making tool for program administrators, planners, policymakers, and other health officials. So ultimately, evaluation is about learning if the program or policy works. Does it have the intended outcomes? And this is just an example to help you think about programs that vary in terms of new organizational structures, different management strategies, the addition of services not previously available, tailoring to identified needs of different populations, combining two or more programs that have worked separately, but perhaps together now may have some bigger bang for the buck. Thinking about changes in financing or new or changes in existing policy to one or more ranges of outcomes on access, use, satisfaction, function, many of the others, costs, cost effectiveness, disparities, all the way down to mortality rates, depending upon the focus of your program or your policy. Now, evaluation can be focused on process or outcome measures or both. From the process measure side, we think about whether or not the program delivered the services as intended. Did they serve, in fact, the target population they intended at the outset? Did they finish their activities by a certain target date? And was it implemented as intended? That's distinguished from outcome measures that can be quite extensive, but just some examples here are things like improving guideline knowledge among physicians, improving health outcomes and specific types of outcomes in federally qualified health centers, to improve quality of life perhaps among cancer survivors in the community, to reduce readmission rates among Medicare patients, to reduce health disparities, for example, reducing maternal mortality among African Americans, or reducing food insecurity. Can be this or again, any number of other outcome measures. Now, evaluation is grounded in the social sciences in both theory and practice. So think psychology, sociology, anthropology, economics. I'm an epidemiologist by training, but we come back to these social sciences to think about program development and evaluation. Evaluation is also similar to other scientific inquiry. The evaluation in questions and standards are thought of instead of research questions and hypotheses. We have common study designs. There are randomized program evaluations or time series. We often care about comparison groups. We also use common statistics, thinking about how we compare two or more groups or adjusting for differences between people who do and don't participate in the program. Evaluations can also be different in terms of our focus and scope. This is not about pills, procedures, or devices. This is about health and human service programs, delivery models, community-based programs, policy changes or new policies at the local, state, regional, and/or national levels. This is about measuring effectiveness, efficiency, equity, and experience, as well as impacts and costs. It's real world. It's not efficacy under idealized or homogeneous conditions. The flip side of this is what is not evaluation. It is not opinions from program developers or other proponents of a particular program or policy. It is very much human nature to believe in what we developed or work on or funded. And it's especially true if what you are doing feels good and or if you like with whom you work, right? That's a natural prospect. But you have to beware the hype that sometimes comes from opportunities to develop a new program. There's marketing to the community, to potential funders, to peers. I can tell you in my own early stages of my work in evaluation, I was working to evaluate a new regional pilot to improve primary care for high-risk vulnerable veterans. And within days of starting my new job, I heard it's incredible. I was getting comments and emails and calls from Washington, D.C. saying how great it was that they had heard that this program was so effective. But the program hadn't even been launched yet, and we had not collected a single piece of data. So important to be careful. Evaluation is also not a description of just the attributes of the problem or its determinants. It's very useful for thinking about how well the program maps to the drivers of the problem, but it's not evaluation itself. It's also not a description of the program, who leads it, how it's funded, what it aims to do, but without data on what it actually does or has accomplished. And importantly, if you Google evaluation, you will come up with many, many sites for human resources evaluation of staff performance. And this kind of program evaluation has nothing to do with that kind of HR approach. So what can evaluation do for us? Well, it answers questions about contributions of a program or intervention, care model, or policy. I'll use those terms somewhat interchangeably to one or more outcomes. So it could include, for example, things like evaluation of patient-centered medical homes. Did they in fact improve access, continuity, and coordination? Or child abuse prevention programs. Was it in fact successful in improving parent education and support, the provision and receipt of supportive services? Did it in fact have an impact on family well-being, school performance for the children, and reduced incidence of child abuse overall? Evaluation also enables us to compare and contrast the contributions of multiple programs to identify the best ones to use. Now, best has quotes because it can be itself defined in many ways. Most effective, most efficient, or a combination like most cost effective, which doesn't mean the least costly, or best cost benefit, or best return on investment. Even within those, each term may be defined differently. Most effective may be one that achieves the best outcome on average for everyone who participated in the program, or it could be focused on the greatest impact among the most vulnerable. Evaluation also allows us to compare and contrast programs, but that means we also need programs to use comparable measures so that we're measuring apples to apples, not apples to oranges. Evaluation can also help us determine what parts of a particular program or policy work best to improve its own efficiency and effectiveness over time. By way of example, you could think of this about the process for rolling out a multi-component program in stages, doing one component at a time to evaluate outcomes over time to see what addition of each component yields discretely. Or you could implement different levels of program in different regions to understand which level yields enough of an impact. So I think about this in terms of taking a particular area and perhaps implementing program light, something that has some basic infrastructure to it, versus another area where you may deploy more program components at a time and allow you to explicitly and empirically compare and contrast how these different components of the program operate together. I think of it as finding the key ingredients for what you would want to take your show on the road for in terms of spread. Evaluation can also help you justify program and policy decision-making and budget allocations to optimize population health, to minimize disparities, and other federal targets. The Evidence Act is designed to ensure evidence informs strategic planning, program and policy design, and budget allocation. So evaluation can support each of these objectives, helping federal agencies demonstrate systematic, rigorous approaches to decision-making. So for example, does the strategic planning process itself integrate evidence and or use an evidence-based planning process? I wanted to also share some information about some of the most common types of evaluation, and the descriptions of these varies based on the disciplines that generate them. But the key is to think about formative evaluation as one of the most common types, which ensures that a program or program activity is feasible, appropriate, and acceptable before it is fully implemented. This is an opportunity to make mid-course corrections in the process of a program's development and evaluation. They're usually conducted when a new program activity is underway or when an existing one is being adapted or modified. These are extremely useful types of evaluation. Another common type are process and implementation evaluations, and those determine whether a program's activities have been implemented as intended. Process evaluations answer the what, when, where, and how kinds of questions. Outcomes and effectiveness evaluations measure program effects in the target population by assessing the progress in the outcomes or outcome objectives that the program is seeking to achieve. For example, the changes in knowledge, health outcomes, quality of life, readmission rates, and other outcomes of interest I mentioned previously. Impact assessment itself assesses program effectiveness in achieving its ultimate goals. For example, if your program provided local medical providers with intensive STD training to improve the effectiveness of their screening, counseling, and treatment of their patients. And the program worked to improve knowledge, attitudes, and skills among members of your target population and community-based organizations. On the impact side, was the program ultimately able to reduce the overall STD transmission rates in the community beyond those in the evaluation itself? Now, evaluation is a vital tool for program planning, management, and priority setting. So I wanted to talk some about when it's most useful. Well, I would say an evaluation is most useful when the evaluation results, the measures, process, or outcome are mapped to your agency measures. So even if you're not an evaluation expert, you are in the driver's seat in defining the measures themselves, balanced by what can be measured reliably and validly. Evaluations are also most useful when those results are well timed to make decisions. That might sound like an obvious statement, but I can't tell you how many times I've seen evaluators come in and say, I can answer these questions in 3 to 4 years, but the agency and the policymakers need an answer in about 6 months. So there needs to be a connection between the evaluation design and the timing in order to make evidence-based decisions. So you want to make sure the evaluation can deliver in sufficient time for your reporting and decision-making needs. Colleagues suggests thinking about cost, quality, and speed, and picking 2 of those, where if you need something quickly, but you want it to be high quality, you likely are going to need to spend more resources on that particular evaluation. Evaluations are also useful when results are indeed rigorous enough to be useful in decision-making. In other words, avoid garbage in and garbage out. If an evaluation is worth doing, it's worth doing right. And of course, anything that sounds too good to be true probably is. We'll discuss this more in parts 2 and 3 on evaluation basics and evaluation team qualifications. And lastly, an evaluation tends to be most useful when the results are in the context of what else is known about what works, allowing for comparisons across programs as well.
Hi, Becky, this is
Yes.
Susan. Sorry to interrupt. We got a comment. Could you slow down just a little bit?
I can indeed. Thank you.
you.
So how to choose among programs, policies to evaluate? Well, in all honesty, it's unlikely that your agency or office has enough resources to evaluate everything. It's important, first off, that programs be stable and in place long enough to have some level of output or outcomes. In my agency, in the VA, they have prioritized Evidence Act topics where there's a critical mass of research or evaluation evidence already, as well as partnerships with VA program offices where evidence is being used. So in our case, the examples include access to care, homelessness, and women's health. The VA then funded Query, the Quality Enhancement Research Initiative, to help oversee Evidence Act progress. In that case, they then in turn funded a partnered evidence-based policy resource center and a field-based series of evidence-based policy evaluation centers with a coordinating hub in planning. The resource center provides technical assistance on randomized evaluation designs, metrics for use, analytic plans, learning agenda development per the Evidence Act, and a liaison. They serve a liaison role between evaluators and operations and system partners. And in addition to providing programming support and evaluation briefs to ensure that any evidence that is generated is communicated to all the key stakeholders and participants up the chain and down the chain. The evaluation centers themselves conduct specific evaluations linked to agency evidence priorities. These are what I would call content or topic agnostic centers. They do program evaluation for any kind of program or policy that is put forward. There are other strategies for choosing among programs and policies to evaluate that you should consider. One would be population impact. What programs or policies are likely to have the biggest bang for the buck for the individuals and the communities that you serve? Perhaps the focus would be on disparities reduction. Again, what programs and policies exist in the health equity or human service equity space for priority with underrepresented and underserved groups? You may want to think about big ticket programs that represent major parts of the budgets that you oversee. Have they ever even been evaluated? I have seen these kinds of programs in diverse settings, and sometimes the question is are they too big to fail? Meaning, can we in fact have the room and the will to make evidence-based changes in some of these foundational programs? And is there room to make transitions and adjustments to them over time? Another option is to simply start small and build evaluation capacity, talent, and experience in applying evaluation results. If you've not done evaluation before, this can be a little intimidating and a little complex. And so sometimes it's better to start with a small team and a small component of your program and begin to learn how to develop the evaluation relationships, learn how to design these, learn how to prioritize the programs and move forward, but always with a plan for how you would support and accelerate their growth over time. I also wanted to mention participatory strategies. These may include expert panels, stakeholder councils, strategic advice from key leaders, and agency-wide decision-making approaches to help you set expectations around programs and policies and their evaluation as well. It's often very helpful to get input from a wide array of people on this path to choosing which programs and policies to evaluate. I was asked to speak to some of the stages of program and policy development when you should even be thinking about an evaluation. And granted, I've been doing evaluations for over 30 years, and so perhaps not surprisingly, it's an easy answer to me, and that is early and often. I think evaluation, from our experience across a wide array of local, regional, and national projects, is that evaluation should be integrated in the early stages of program development. Part of that is because the structure of evaluation design itself can help structure program development too. For example, with its strong emphasis on clear and measurable goal statements and SMART objectives. There's also an opportunity to consider how something would eventually be evaluated as you're thinking about program development. It's what in fact do I think this program or policy can accomplish, and how would I go about measuring that at some juncture? It also enables pre-planning on collecting outcome and other measures at baseline before the program is either completely implemented or even before it's been started at all. I can't tell you how many times I have had individuals come and tell me, I have the best program ever and it really works, and could you now evaluate it? And the reality is my opportunities and options for providing any kind of evaluation have now been limited by the fact that there was no baseline information. Now, that said, it's not always possible to integrate evaluation in early stages. So then what? Well, any program or policy can be evaluated after it has been launched, even years in. Some of that depends on the program's life cycle. Some programs are time limited. They are given 5 years of funding to accomplish some goals or objectives. So in those cases, that can be a little bit more challenging. But others are longer term or have no specific end date, and that creates more opportunities to evaluate both the short and the long-term benefits, to consider what it takes to maintain those programs, and to be thinking about sustainability as well. So how do you approach evaluations of existing versus new programs? Well, new programs sometimes come with new resources, and that can enable development and evaluation time and funding. And that can create a great opportunity for the combination of evaluation with program development. Proactive evaluation planning is key if those innovation resources are going to go away. Often evaluation is used to provide the rationale, the business case, the return on investment, the impacts on why this program in fact should be sustained. If new programs are to be implemented, however, without new resources, they may have to compete with existing programs for funds. In that case, evaluation may actually be even more important in that scenario, but evaluation funding may squeeze budgets too. So you'll have some push-pull in that arena. Existing programs typically have the advantage, in contrast, of having been fully implemented. So they can be a little less risky, as the new programs don't always come to fruition, or they may take longer than anticipated to be fully implemented, which then stalls the evaluation. I have been in situations where we have hired an entire evaluation team, but the program components simply aren't ready. and you either have to put people on hold or you begin to evaluate early stages, as the case may be. Now, existing programs typically also have other challenges. There may be vested interests with some of them, with or without evidence of effectiveness, and they may or may not be open to evaluation. I have definitely come to sites that simply were not interested in anyone coming in through the doors, and thinking about how to work that through has another set of issues with it. I also want you to be thinking about how none of this really starts from a de novo position. I want you to think about how to integrate prior evaluations into your evaluation planning. In reality, there's very little that is completely and utterly novel, with a few exceptions. So it's really important to take stock of what's been tried before and learn from it. Consider programs and policies, for example, that have been tried for a related problem or for a different population, and think about whether or not they could be adapted to your program or population. It's important similarly to compare your program planning and evaluation to standards and best practices where possible. Just a couple of examples. Maybe you are supporting a community-based program that's focused on diabetes prevention, but maybe many of the attributes of that program could in fact be helpful for hypertension control or hypertension prevention as well. Or maybe you have a program that reduced disparities in African American youth, but that could in fact be tailored to work among Latinx youth in another region. So realize there's a tremendous wealth of information out there on what people have tried to accomplish. So the summaries of what works may be available through existing systematic reviews of the published literature or other means. So I want to introduce you to evidence reviews, which may provide timely and accurate syntheses of targeted topics of importance to programs, agency staff, and policymakers. Evidence reviews may be used to develop policies informed by existing evidence. They may be used to implement effective services to improve outcomes and support evidence-based guidance and performance metrics. Evidence reviews may be used to appraise current programs in the context of new evidence, and they may be used to set directions for future research and evaluation to address gaps in knowledge. Now, where evidence isn't sufficient, expert panels may also help you understand what has worked previously by combining systematic review evidence that does exist with expert opinion to fill key gaps. And this is a widely used process to address those kinds of problems. So I wanted to talk to you briefly about how to use existing systematic reviews that might be relevant to your evaluation. There are several types of systematic literature review that are available. For one is just what we would call the plain old literature review process, where you get on some online search engine for the published literature, and it's a curated information gathering, often to help you define and refine the understanding of the problem itself, the why should we care component. Systematic reviews gather information typically, though, within a specific scope. They actually include steps for appraising the quality of the information, often whether or not it's randomized trial evidence or some such. And they provide you some kind of sense of the confidence in the findings across the studies that they look at. Within systematic reviews, there's also a process called a review of reviews that summarize findings across multiple systematic reviews. For example, we identified over 16 systematic reviews focused on provider burnout. So we synthesized all 16 to come up with an aggregated set of information. Meta-analyses are another form of review that use highly sophisticated statistical combinations of evaluations that have similar goals to come up with some statistically aggregated answer about what works. And I'll show you an example in a moment. And then on the flip side of those are evidence maps, which are broad scans of a larger field of evaluations, which give you a notion of where research and evaluation has been done and where a lot of work has or has not been done. On the systematic review resources, and these are examples, this is not an endorsement of any particular resource. We often use bibliographic search engines such as PubMed. We also sometimes can work with the Cochrane Collaboration. This is a global group that emphasizes supporting evidence-based medicine and decision-making. They've established standards for literature review, such as search strategies, inclusion and exclusion criteria, abstraction standards, peer review, quality review criteria, as well as publication standards. And there are Cochrane centers around the world, including many in the United States. Another example is the ARC Evidence-Based Practice Centers, the Agency for Healthcare Research and Quality, which uses Cochrane standards to generate evidence reports for a wide variety of health problems. So the message here is really you don't necessarily have to start from square one. There are lots of resources online across health and human services. I also wanted to mention the VA has an evidence-based synthesis program that's actually linked to the evidence-based practice centers as well. And I wanted, by way of example, to show you I've been helping our agency better understand what works to reduce healthcare employee burnout. It took less than a minute to find 118 systematic reviews on health and safety in work, less than a minute. It would obviously take longer to find the ones that are closer fit, but I'll get a lot of ideas as I review these too. Now, a review of reviews, by way of example, may help answer questions about comparative effectiveness. So agency leaders wanted to know whether they should continue to invest in continuous quality improvement to improve clinical care delivery. And this review of reviews basically said yes and no. CQI works in specific contexts. There's lots of evidence, regrettably, but it's of low methodologic quality. And no one has cornered the market on the best framework to use. And context matters as to whether CQI works or not. So it is not a one-size-fits-all solution. Now, reminder that a meta-analyses are highly sophisticated statistical combinations of published evaluations and research with similar goals and outcome measures that comes up with some aggregated answer of what works. I wanted to show you what one of these looks like. In this example, you get a nice visual representation of how spinal manipulation works in a bunch of randomized trials compared to usual practice, whatever that was for each one of these. Now, high scores, if you see the red arrow here, high scores are actually worse pain scores. So anything that's negative is actually good, anything on the left of that line. So without advanced statistics, you can look at this and see that spinal manipulative therapy is an effective treatment in reducing short-term pain. You don't even have to read the paper if you don't want to. So these visuals can in fact be very helpful. In this example, I wanted to show you how many different types of interventions can be compared and contrasted. In this case, for improving adult immunization and cancer screening services. You can quickly see in this example that organizational change is the most effective intervention for immunizations, cervical cytology, and colon cancer screening. But for mammography, it's patient financial incentives. Just as important are the strategies that are the least or not at all effective, including those simpler things we often try to do first, like feedback, tell people how they're doing, or patient education, which may be necessary, but never sufficient on its own. Now here's an evidence map example on the other end of the spectrum. Remember, these are broad scans of the literature to learn what kind of work's been done and where the gaps are. Here, if you look at the tall bars, you'll see that there are 100 or more studies in these taller bars in each section, which demonstrate that there are over 100 or more studies on health disparities among veterans who are racial and ethnic minorities. But in contrast, we know very little about the health disparities of transgender, disabled, or homeless veterans, those small bars towards the right of each section. In this way, an evidence map can help you think about where new programs may need to be developed and or evaluated. Now, lastly, this evidence map shows you the types of interventions that have been tried for different disparities. So on the left side, you'll see system level, technology, provider-focused, patient-focused, and multi-component. So you can see at the top here with those big circles that these are mostly observational, big data studies. But given the different colors of the circles, you can also see that the evidence in these different types of populations is also mixed. The purple bubbles, the yeses, also show which interventions worked. And you can see here that most of those are in the technology category or are patient-focused. That means there's a lot of room for us to think about provider-focused and multi-component interventions, as well as other work that needs to be done for other populations. So how do you integrate prior evaluations into your evaluation planning? The real challenge is, what if you even can't find any, despite all the tools and resources I described at your disposal? It is possible that many programs have been tried but not evaluated. And for that, I say buyer beware, because in the absence of evidence, even if someone has been running a program for some time, you really can't speak to whether or not it's been effective. There are also other programs that have been evaluated and may have some data but are not published. This is often represented in what we call the gray literature: reports, working papers, newsletters, policy briefs, mounds of government documents, even speeches that sometimes provide a very compelling argument for why something may work. The challenge with that gray literature is that it has typically, if ever, been peer-reviewed, which means they are representing their work with unknown rigor. They may be opinions and statements without evidence, and the work has been conducted with uncertain qualifications. Expert opinion, as I mentioned before, can help fill gaps and help inform evaluation planning in these circumstances. I thought of two examples in this area. One we're working on right now on a congressional mandate to evaluate the prevalence of intimate partner violence among veterans. The legislation required a literature review and a study without specifying much more. To bring these two pieces of sets of evidence together, we recently convened an expert panel of researchers, policymakers, providers, and community members to try and sense make across this information to inform a task force that will make decisions around an evidence-based comprehensive IPV program. Another example is that perhaps you have a literature review of what strategies reduce gun violence, but the evidence is limited. So in that case, you may again want to convene an expert panel of policymakers, community leaders, researchers, and others to take what is known about the literature review, combine it with expert opinion to make some evidence-based recommendations. Either way, the recommendation is to also consider contacting your evaluation office or liaison in your agency if you cannot find any prior evaluations. So as we are working through these examples, and I want you to be thinking about how you can use evaluation results for program planning, management, and priority setting. So let's say you've gone through all of this, you're overseeing or even developed and implemented a program, and you have evaluation results ready. So now what? Well, as I often say for my students and colleagues, it depends. It depends on whether the program was found to be effective or not. If it's not effective, that process evaluation I described earlier could be instrumental in helping you understand why the program didn't work. Was it a problem in how the program was implemented, or in its theory of cause and effect? Was the program ever in a strong position to have the outcomes of interest? If it was effective, you need to think about whether or not the program, and the program did work, it improved outcomes, but did it do it a lot or a little? Now that becomes important because if it made some statistically significant but very minor improvement, you're going to need to make decisions about whether the program's efficiency and effectiveness could be bolstered. Can you improve its impact? And whether or not the program costs are worth those incremental gains, even though they're statistically significant, let's say. Now, if the program worked a lot, however you define that, you still need to consider the significance of the gains, whether or not those gains were on average improvements that were statistically significant, let's say, or whether or not there were gains for people that were already likely to do well versus gains for people that needed to do much better. In other words, do you need to tailor the program further or push it to make sure that it's serving people with greatest need? And then you have to consider costs as well. That return on investment, the cost benefit, the cost effectiveness needs to be part of that consideration when a program works. The other issue is that it depends on whether the program was significantly better than other programs, perhaps aiming to achieve the same goals. And that may indeed have implications for which is sustained, so that evidence indeed needs to be rigorous. If you're talking about concluding a program on the basis of evidence, it needs to be quite strong, irrefutable perhaps, and strong enough to have the decision make good sense on the other end. If you do not have that kind of evidence, we often recommend people continue to evaluate the set of programs aiming to meet the same goals, or consider whether or not some programs work better for some communities than others, and have that part of your explicit priority setting and management process. So with that, I'm going to turn us over for questions and answers. And I'll stop sharing at this point.
Thank you very much, Becky. Again, I apologize for not showing my camera, but it decided to stop working around noon today. But thank you so much, Becky. We really appreciate all the information that you shared with us, and we do have a number of questions. If people have additional questions, please put them in the Q&A function, and we will try to address them now or have a document that comes out later, a frequently asked questions type of document. So we will get to your question. And so the first one that we received is comparable measures. You mentioned that in one of the beginning slides, and you talked about comparing apples to apples and not apples to oranges. Could you offer a little more context regarding that, or an example of how you would sort of determine what's apples to apples,
Happy to do so. I think about some of the work that's been done in suicide prevention, and there are measures of suicidality. So that you have a notion of whether or not people are less suicidal, that they're less likely to attempt suicide. And there may be 3 or 4 different validated measures that you might find on a literature search. The question is if you compare multiple programs and they've all measured suicidality differently, then it's going to be somewhat difficult to compare those programs. Or intimate partner violence. In our expert panels last week, we spent a surprising, actually to me, amount of time on the different definitional aspects between the Centers for Disease Control, the Department of Veterans Affairs, community-based definitions, and realized that if all these definitions differed, what actually goes into saying someone has experienced intimate partner or domestic violence is going to vary. And that means that, again, we may be faced with apples and oranges across different programs that have sought to reduce intimate partner violence or address needs after such exposures. Does that help?
Thank you. Yes. Another question, is there a recommended time frame for a program to have run in order to have a substantive level of outputs or outcomes? Great
question. I would say, again, it depends. In part, in one of the main evaluations I did in the VA years ago, the program itself was a profound transformation of care teams into what they called academic global care teams that had a novel electronic health record component, substantial training, and even physical plant renovations to create seamless services around primary care assigned patient populations. When you're talking about something that includes space renovation, training and potential licensure issues, and any other complex components, any one of those steps is likely to delay having the entire program in place, right? So if I evaluate that program when half the building's under construction and not everyone's been hired and some of the folks have not been trained, I'm giving the program short shrift because it's not fully built, right? Literally and figuratively. In other situations, it may be simpler to say, okay, this requires training and we're going to install a specific reminder, or we're going to head to 10 different clinics to do some kind of activity with them. And it may be easier for you to know that the program is in place. So it depends upon the program complexity and how multifaceted it is, how and when you really feel like it's stable enough for you to go. Even in that first example, we found we really couldn't do a full baseline because of the way even the evaluation was funded. And we ended up calling it kind of early versus late. And that's okay too, so long as you're clear that the program was in its very early phases, and that's when you decided to collect data. In some cases as well, it's good to have many data points if you can. Of course, every time you collect data, it costs more resources for not just data collection, but analysis and reporting. But in some of those situations, if the program is going to take quite some time to roll out, those multiple data points start giving you some insights into how fully fleshed out the program in fact is. That can also be a good time for what we described as formative evaluation, where you in fact can feed back to the program developers and leaders. By the way, you think the program's fully developed, but here's a bunch of the areas that haven't been as implemented as you think they have been. You may want to shore those up before we start the outcomes evaluation.
Thank you. And I would also emphasize for everyone, particularly folks that work with the programs, know the programs, are topical subject matter experts. That's where, as evaluators, we really need your input to really know, are things implemented as much as we think, just as Becky was saying. So we encourage you to partner with the evaluation teams. Another question: what have been some unexpected challenges you've experienced when trying to plan an evaluation? And I say that with a smile in my voice.
Thank you. And I'm smiling as well. Gosh, more than I can probably do justice to in the time. I have had, I think one example is actually a child abuse prevention project we worked on years and years ago, where suddenly the volume of referrals from the family justice court, that stayed high, but the program's throughput of referrals to comprehensive services to the community suddenly took a sharp fall. And we rapidly went in to do a process evaluation in those sites and began interviewing program participants, program staff. And what was fascinating is that they all uniformly said, well, actually, we have all of those referrals and they're in my bottom drawer right here. And we stopped and said, well, why aren't you processing those? And they said, well, the program leader said, if you don't get everything done in 2 weeks from when we get it from the court, I don't want to see it. So they operationalize that explicitly and just put them all in the bottom drawer. So going on site, talking to people, understanding what the unintended consequences may be of shifts in directives, shifts in planning or policy can be incredibly important. I have seen also substantial turnover in programs over time, where you need to make sure that both the program and agency leaders and the evaluators communicate what's going on and what the expectations are for evaluation in the field. I've also during evaluations found that people think that if something is being evaluated, that you're doing some special program that will probably be taken away. So I've only learned through evaluation that in some cases, when we've implemented, let's say in this one example, a depression collaborative care model in a few dozen primary care clinics, that one site saw that one provider in particular was consuming all of the referral options and none of the other providers were really using the new program. And we found out that the person thought this was research and thought this would really helped him with his patients to have his patients' depression managed, and they got better, so they were able to help manage their diabetes and their other issues better, and saw it as a constrained resource that he actually didn't want to share. So he missed the part of the program that was about being a clinical champion and sharing this program with others. And in other places, you learn challenges in everybody capitalizing on the program, but the program itself not doing well in evaluation because they did not anticipate demand. And so as providers began to use a program more and more and more and more, the program wasn't capable of keeping a pace. And very quickly, providers stopped using the program because they're like, well, nobody can answer my calls. Nobody's responding to my referrals. And so again, both the evaluation and the program have this commensal relationship with each other in terms of how they inform future changes to the program and the policies themselves. So I hope those are some examples. I have had, I think one other was where we did deliver results that demonstrated that a program did not have the intended effects. So we had someone say, well, we're not going to pay the contract. That's why it's good to have contracts for both the program and the agency, and for if you contract out with evaluators so that if you're delivering bad news, there is a plan for how you actually account for that and how you think about it and how you have considered that even at the earlier stages of program development and evaluation. That ultimately worked out just fine. And the program, instead of being defensive, shifted to what else can we do in the program to, in fact, accomplish the outcomes we meant to there. But it becomes a conversation, and that's where the value in participatory evaluation lies as well. So just some examples.
Thank you, Becky. And on that last point, I will also chime in that the HHS evaluation policy does require that evaluations be made public in a timely manner. And so having some of those discussions up front in an intermediate frame, and then at the end to understand what are we going to do if the results aren't what we want them to be? How are we going to use that? How are we going to take an approach that is a helpful approach? And we weave that in, and we do that from the beginning. And again, as Becky said, make that a conversation. So we are almost out of time for questions. So I do want to acknowledge that we have some actually quite substantive questions here. And I think that it's best to give quite substantive answers. So we will respond to those in writing and post that material when we post the recording. So for example, one of the substantive questions is, there seems to be much talk about evidence-based practice. Are there any evaluation methods for practice-based evidence, especially for Native and Indigenous peoples that may not have the capacity to integrate or prove that their healing practices are just as effective or even better than Western-based medicine? So I don't want to give that type of a question, that really substantive question, short shrift. So we have received it, and several others that are equally weighty. We will respond in writing to those. We will provide some information on those. In terms of one last question, let's see. What are your thoughts on evaluating culture changes like increases in DEIA, so equity area, success, measures such as reduced microaggressions towards those identified as transgender or Native Alaskan?
Excellent question. I'm actually, there's substantial work going on in that arena, and the development of reliable and valid measures of things like microaggressions and culturally appropriate measures, so that when you assess the prevalence of these concerns in different communities, you're doing it in a way that captures the experience in a meaningful way. Work is underway on doing better jobs in all of those areas. And so again, I'd like to respond to that one in writing afterwards. But I just know that there's a tremendous amount of work to get that right, so that that's a global we as program evaluators, health services researchers, human service researchers, and the like, can ensure the access to good measures to use in program evaluation across the country. I don't think that those tools are necessarily available as yet, but I know that there's a lot of initiatives out there for improving measurement and improving their inclusion in a wide array of program evaluation activities. I know that in my own work as well. So we work with different program offices in our area to make sure we're using measures that are standard within the field, basically. So I hope that's a helpful initial answer, but I agree, Dr. Jenkins, that it warrants a fuller answer after this session today as well.
Thank you. So with that, I will turn it over to Academy Health, and we have a survey. We are very interested, as this is the beginning of our Evidence Act capacity building training series, of this series of 3 trainings, but also we are developing trainings over the next several years to address the capacity assessment that HHS did under the Evidence Act. So I will turn it over to Academy Health. We have a few questions that we really encourage you to respond to help us to improve these trainings.